This is Dr. Caldwell Miller, Dr. Miller's Guide to Neurology. We're going to talk about a fairly classic neurological condition that's fairly rare, and it's called a brachial plexopathy. You know, the nerves that come out of the neck go through the underarm, and there's a group of nerves in the underarm before they go to the arm. It's called the brachial plexus. And the brachial plexus can be injured. It can be injured when it's stretched. We see people with hyperextension injuries in their shoulder. Arm can be almost torn off, and you can see severe brachial plexus injuries. You can see it from manipulations of the shoulder, like when someone has a dislocated shoulder and someone's sort of inexperienced in the emergency room and just keeps trying to relocate their shoulder and get a brachial plexus. You know, so very commonly see it with trauma. You can see it from post-viral. People say they were sick about 6 weeks earlier and then they develop acute weakness in their arm. You can see it post-vaccination. And I won't say it's any more common with the COVID vaccine than it is other vaccinations. We see it with military recruits. You know, people blame COVID for these kind of post-vaccination plexopathies, but we've just given hundreds of millions of COVID vaccinations, and if it was a real mainstay of that particular vaccine, we'd have seen a lot more than we do. So it's any vaccine. And I think it's an autoimmune thing, just like it is for a virus, where you get a virus or you get a vaccine and the antigen on the vaccine very similar to the antigen on the nerve, and as your body develops the antibodies to that particular antigen, it attacks the nerves and causes this plexopathy. You can see it post-operative from anesthesia. You can see it. I've seen patients that were dropped off the table, you know, when they were moving them from bed to bed, and an unconscious patient. You see it in stingers in football. You very commonly see, you know, brachial plexus injuries in newborns, particularly breech deliveries. See it with the radiation. You see it with infiltrative cancers like breast cancer. We most commonly see it's idiopathic. Patients just awake with excruciating shoulder pain and weakness. And man, we like to see these people early, and there's been no great studies, but for decades, if we see patients early, we know this what this is, give them high-dose prednisone, they do so much better. 60 to 80 milligrams a day, and then taper off for 2 to 4 weeks. There are three main types. The most common type is an upper trunk brachial plexopathy. It's mainly the proximal shoulder muscle, C5-6. The orthopedic guys call this parsonage-Turner syndrome. Severe pain with proximal muscle weakness, classically in the deltoid biceps. The hand is very strong. This is an upper trunk brachial plexopathy. The lower trunk mainly involves the ulnar innervated or intrinsic hand muscles, severe hand muscle weakness. Probably I'll see 100 upper trunk brachial plexopathies before I'll see one lower trunk brachial plexopathy, except in the setting of trauma. And then the third type is just complete brachial plexopathy involving all three trunks. So that's brachial plexopathy, and I would say the thing that bothers me the most is we don't diagnose this quickly enough. So if you have acute shoulder pain, you wake up and you're dying and your shoulder is weak, you should see your doctor immediately. Acute brachial plexopathies respond so much better to rapid treatment with steroids. So that's brachial plexopathy. Like, comment, subscribe. More later.